In Japan, we have public health insurance scheme which covers the whole population. There are about 3,000 health insurance bodies. Some of them are occupational-based and some are community-based. And people in Japan have to join one of the health insurance bodies. And in 2010, annual medical expenditure is about 37 trillion yen, which is about 7.8% of GDP. And about half of the expenditure was paid by insurance premiums, and 38% are paid by general tax. And the rest, about 13%, was paid by patients. And health insurance coverage decision and reimbursement prices are determined by the Ministry of Health, Labor, and Welfare. Coverage and prices are the same for all health insurance bodies. Prices are revised every 2 years, and health technology assessment is, I would say, partly implemented, especially for clinical efficacy and safety. However, there are no requirements of economic evaluation for procedures and drugs. The Ministry of Health, Labor and Welfare decides the coverage and prices based on the consultation with Central Social Insurance Medical Council. It's too long, so I call it Chuikyo. Sorry, it's in Japanese, but I call it Chuikyo here after. So Chuikyo has a role of decision-making. And Chuikyo consists of 7 representatives from healthcare providers, 7 from healthcare insurers, and 6 from public perspective. So Chuikyo is a place where healthcare providers and payers negotiate insurance coverage and prices. And there are several committees under Chuikyo. For example, Basic Problem Committee is responsible for coverage decision and pricing of medical procedures. Under the committee, there is a Health Technology Assessment Subcommittee. However, it does not consider cost effectiveness of procedure so far. For drugs and devices, there are special committees for those. For new drugs, there are 2 methods to set base prices. One is based on comparison with similar drugs. Similar drugs are chosen regarding similarity in pharmacology, chemical structure, medication method, and form. After the base price is calculated, the drug may be applicable for some additions. The other method is actual costing method, which is applied when there are no similar drugs to the new drug. After this process, the price may be adjusted to take the foreign price into account, and the price will be finally determined. In a similar drug method, base price of the new drug is calculated as the daily expenditure will be equivalent to the daily expenditure of the similar drug. It seems reasonable as far as the similar drug is adequately chosen and can be thought to have equivalent in efficacy and safety. But if the new drug is more effective than the similar drug, the new drug can be priced higher than the similar drug. It is called innovative addition and useful addition. Innovative addition is 70 to 120% of the base price, and it is applied when the new drug is developed with innovative idea and shows extremely high efficacy and safety, and contributes to large improvement in treatment of the target disease. Useful addition is 5 to 60% and applied when a part of the 3 criteria for innovative drugs is achieved. This pricing rule may reflect additional benefit by a new drug compared to the similar drug. However, we are not sure about how much addition will be applied to each drug. In the costing method, base price will be calculated from actual costing data submitted by the pharmaceutical companies. Costing data are supposed to include cost of research and development, as well as the cost of producing and distribution. However, those costs are calculated by using fixed proportion for cost of R&D and marginal profit and distribution, based on the survey of average of pharmaceutical industry. And current issues of medical expenditure in Japan. Medical expenditure in Japan is increasing every year. because of not only population aging, but also innovation of new technologies. New advanced technologies and treatment are introduced, including drugs, and many of them are high-cost technologies. If insurance premium or tax funding are limited, we have to consider efficient use of healthcare budget. And we have patient co-payment of 30% for both inpatient and outpatient care. However, if monthly out-of-pocket payment exceeds a certain level, it will be paid by insurance, which is called high-cost medical care benefit. Expenditure for this high-cost medical care benefit is expanding. If we assume the expenditure in 1998 as 100, total expenditure, health expenditure, is 117 in 2008. However, this high cost of medical care benefit is 215. And this is partly because of a policy to increase patient co-payment. However, introduction of high-cost medical technologies is another reason. And from 1992, pharmaceutical companies are allowed to attach the result of economic evaluation to the new drug application dossier. It is not mandatory, and there are no guidelines for the methods of study. And for medical devices and procedures, approximate cost estimation should be attached. And this is the number of evaluation data submitted to Chuikyo. In the case of drugs, only 8 studies during 5 years were submitted. And for devices and procedures, total number of studies were high, but most of them are just cost estimate of the new procedures. Under such situation, the need of health technology assessment, especially economic evaluation, is pointed out. In 2010, a member of Chuikyo from a public perspective mentioned it should be make decision based on economic evaluation. In 2011, Drug Pricing Subcommittee proposed to adapt economic evaluation for decision-making in the future. And finally, in April 2012, a new committee on cost-effectiveness evaluation was established under Chuikyo. And members of this committee are 6 healthcare insurers and 6 healthcare providers and 4 publics. And up to here, they are chosen among Chuikyo members. And in addition, 4 members from industry, these are pharmaceutical and medical device industry, and 3 experts in this field, including myself. And there are the issues to be discussed at the Cost Effectiveness Evaluation Committee. Firstly, we discussed 2 basic concepts of the system. One is principles of target technologies, and the other is principles of application of results. In the committee, we have agreed how to prioritize technologies to be evaluated. Those are the technologies not for rare diseases, and there exist alternative health technologies and technologies which may bring large financial impact because of high unit cost or high volume of patients, and there's evidence of efficacy and safety. We also agreed that reimbursement decision and pricing should not just based on cost effectiveness analysis. Other factors must be considered. And now we also discussed some methodological issues, such as perspectives and extent of cost and outcome measurement, if we use quality as an outcome measure, even though we haven't reached consensus yet. Now our main topic is how to use economic evaluation results. Under the current reimbursement decision process, we can use economic evaluation results to determine insurance coverage itself or reimbursement prices of procedures and drugs. I think we can divide HTAi, health technology assessment, in 3 steps: assessment, appraisal, and decision-making. Assessment is a scientific approach to analyze efficacy, safety, and cost-effectiveness. It should be based on appropriate method from academic point of view. And appraisal is how we interpret the result for example, cost per query. At the same time, we need to consider other factors, such as ethical and social factors. Based on the appraisal, final decision of reimbursement and pricing will be made. In the Japanese system, final decision must be made in Chuikyo, and the assessment can only be made by academic experts. The issue is who should do the appraisal. Should it be made in Chuikyo as well? We need another committee or organization for that purpose? Well, who should be in the member of the appraisal committee? And do we need criteria for appraisal and so on? Our next reimbursement price revision will take place in April 2014, and intensive discussion has been made aiming for the trial implementation in the next revision. However, we have several issues to be addressed, such as formal process of HTAi and timing of evaluation and assessment body and evaluation guidelines. So we appreciate your advice to implement HTAi in Japan. Thank you very much for attention.